Good morning, everyone. It's a great pleasure to be here today and present our own Chief Resident, Dr. Dina Al-Rais. Dina joined us several years ago as a researcher for a year, and then she joined our residency program in APCP. Dina has been active in research, several areas. She has interest in GYN, breast and skin pathology. She published several papers and presented several abstracts, meetings, and she will be finishing her residency, I think, June this year at the University of Minnesota, and she will be joining us again in the GYN and Breast Pathology Fellowship. We are happy to have Dina with her positive attitude towards academia, towards research and publication and learning about pathology. And today, Dina is going to talk to us about GATA2 immunohistochemistry in uterine serous carcinomas. Good to have you, Dina. Go ahead.
Thank you so much. Thank you so much, Dr. Khalifa. And thank you, everyone, for being here today. And as Dr. Khalifa said, I would like to talk to you today about GATA2 immunohistochemistry in uterine serous carcinomas. And I would be focusing mainly on the prognostic significance and the clinical implications. And let's move forward. I don't have any disclosures. So before we begin, I want to quickly go through my objectives for today. So I'm planning today to review the clinical and pathologic features of uterine serous carcinoma and the current management challenges that we have, and then review the role of GATA2 immunohistochemistry as a prognostic marker in uterine serous carcinoma, and finally end with discussing the potential role of GATA2 stain in prognostic assessment and its implications for future adjuvant therapy decision-making. So let's first start from the very beginning. I want to give you an kind of a quick review of uterine cancers. So uterine cancers is ranked as #1, the most diagnosed gynecologic cancers affecting the female reproductive organs. And then when we look at worldwide, it is ranked actually as #4 of overall diagnosed cancer among women. And if we look at our population at the US, it's ranked as the 9th most common diagnosed cancer among both sexes, males and females. So it's very common tumor. And if we're going to classify uterine cancers into mainly two main groups, it would be carcinomas and sarcomas. As you can see here, I hope you can see my arrow here. As you can see here, the majority of the cases that we actually see every day is mainly carcinomas, and a small portion of it are sarcomas. And when we're talking about the carcinomas, the most common carcinoma that we see in the uterus is the endometrioid adenocarcinoma, and then followed by other types or other subtypes, histologic subtypes, I would say, like the serous carcinoma and clear cell carcinoma and others. But what is concerning is that recently, in the last decade, there is an increase in the incidence of the new cases that have been diagnosed with uterine cancer, and that is by an average 0.7 each year. And you can see that here. This is represented by the light green squares. And you can see here, starting from 2023, there is a steady increase over the years. And then what is also concerning is that when we look at the age-adjusted death rates, which is here represented by the dark green triangles, also almost the same period, like from 2004, maybe around here, till 2023. So you will also notice that there is increase and steady rise over the years with an average of 1.6%. And one might think that, okay, maybe there is increase, but it's kind of like an even distribution among all histologic types. But actually, that's not the case, because unfortunately, when you look at these charts, you will see, for example, we said that the endometrioid is the most common carcinoma in the uterus. But then when you look at this one, for example, on the left side, the orange dots here representing the endometrioid, and that in like a project that I found online that was published studying Black women. And you can see that it is still rising, but it's very stable rising, not like dramatic rise. But then when you look at the blue dots here, which representing serous carcinoma, you will see that it's increasing really fast over the years. I would actually even say, according to their chart here, they are predicting that at some point in the future, we might have the serous carcinoma more common than having endometrioid carcinoma, especially in Black women population. And then on the right side, the chart that I'm trying to show here, basically, we can classify the carcinomas in the endometrium into two main groups, like type 1 and type 2. And that is, think of it not just like for specific histology or something, but more of the behavior. So usually type 1 are the ones that are less aggressive, and type 2 are usually the ones that are more aggressive. So type 1 usually include the endometrioid with its 3 grades, and type 2 usually includes mainly serous carcinoma. Other types, of course, like clear cell or the triple MT, but it's mainly serous carcinoma. And you can see these bars here reflects the change in percent. So the blue ones now are the endometrioid, and you can see that there is no much change in the incidence of or the diagnosing of new cases over the years. But then when you look at the type 2, which is mainly represented here by serous carcinoma, you will see that there is a dramatic change every year. There is an increase with approximately 5% every year. So let's talk a little bit more about uterine serous carcinoma, because it looks like it's really rising and it's very, very aggressive tumor. So regarding prevalence, again, as I said, it's not the most common. It actually accounts for only 5 to 10% of all carcinomas in the uterus. But unfortunately, when you look at mortality because of the mortalities that happen because of endometrial cancers or endometrial cancer deaths, you will see that uterine serous carcinoma actually accounts for 40% of that, which is huge when we're considering that it's only 10% of all cancer that happens or carcinomas that happens in the uterus. And then uterine serous carcinoma, usually, if not always, we see it in postmenopausal. So the median age for at time of diagnosis is 72 years. And as I said, it's almost exclusively in postmenopausal women. And that is kind of, it's important, and I will talk later in the following slides about this, but I just want you to remember that the population that we're talking about here are elderly women, and that is very important for the following slides. And then when we compare it to the endometrioid, for example, endometrioid is known to be associated with estrogen and obesity, but the uterine serous carcinoma doesn't have that strong association with obesity and estrogen. Molecular-wise, the TP53 mutation occurs very early in this disease, and I would say it's kind of like almost a universal signature for this tumor, where more than 90% of the uterine serous carcinoma, usually you will find a mutation in the TP53. Uterine serous carcinomas also belong to the copy number high and the P53 abnormal molecular subgroup. Of course, there are some other mutations and alterations that we see, but this is the main thing that we almost always see in all cases. Other mutations that we can see, for example, the HER2 or the ERBB2 amplification and the PI3K mutations. Grossly, it's very, very variable. There is not like features that we can use to identify the uterine serous carcinoma grossly, or even differentiate it from any other non-serous carcinoma. And it's very variable that it can present as a very aggressive tumor, as it is like very large mass invading the surrounding, maybe reaching to the cervix, maybe even going to the pelvic cavity and literally invading everything. And maybe also you can see some necrosis in it because it's very aggressive. But then on the other hand, it can also be presented as very, very subtle, occult mass that sometimes it's not even a mass. Sometimes it's like just confined to a polyp, and not even the whole polyp. It could be just like involving part of the polyp. And in some cases, we actually don't really see it at all grossly, and we just identify it microscopically. So it has a very wide range of presentation grossly. Microscopically, so let's start first by low power. So uterine serous carcinomas, they can present with different patterns. I would say the most common pattern that everyone is used to see is the papillary pattern or architecture. And that's why in the past, it's actually used to be called uterine papillary serous carcinoma, because at some point it was thought that it has to have a papillary architecture. That's how it was that common to see the papillary architecture. But there are other architectures that we can also see. Like, for example, here, there is the glandular architecture when it's trying to form glands. We can also see solid architecture when you can see sheets of high-grade cells. And then we have the mix and match. And I would say maybe, at least based on my limited experience till now as a trainee, this is, I think, the most common thing that I see. It's kind of like a mix, usually papillary with something else. Like, for example, here you see papillary, and then maybe if you look here, you will start seeing some glandular component as well. And then let's go slight more high power. You will start notice that the glands are elongated, and it's kind of like not, it's a very soft sign, I would say, but it's noticeable that the glands, like, for example, the whole gland is kind of like stretched or elongated. But the one feature that I really, really like is the slit-like spaces, the lumen spaces. And you can see that here. It's kind of like, I don't know, it makes it easier for me to identify it even on low power. You will see that slit-like spaces as if the tumor is cracked or something, but I really like it. And I think the explanation for this is some cells are trying to have this. If you look closely, you will start seeing maybe like papillated kind of cells, or they're trying to maybe like snouting, although snout is not the buzzword to use here. But when the cells trying to form this like small papillae like, then we start seeing the spaces between them as slit-like, and that's why we see it diffusely here. And then going even more high power, you will start seeing very, very pleomorphic cells, very high grade. The nuclear membrane, it's kind of like very irregular. And one of the very common features to see is very large, prominent, sometimes even we call it macronucleoli, like what you see maybe here and maybe here. And sometimes it has this red tinge, or like maybe kind of like pinkish discoloration. And I don't know, when I look at it, sometimes I feel that the pleomorphic cells are staring back at you with this very prominent nucleoli. It will be very easy to identify. And because it's very high grade, so of course you will see a lot of mitosis in the majority of the cases. And because I told you earlier about how subtle it can be, so I just wanted to show an example of that. So you see here, for example, this is a uterine polyp, and this uterine serous carcinoma is involving only the surface, not even the whole polyp, but only the surface of this polyp. So it can be as subtle as that. For staging, so I want to say it's kind of confusing, but it's not really confusing. I would say it's more of that we are in a transition phase. So before 2023, how did we stage the uterine cancers? Staging at that point was mainly focusing where the tumor is. We didn't care much in staging on what the tumor looked like, if it's low grade or high grade. And that's why you will see here that it's focusing, for example, if it's only superficial, like in the endometrium, maybe invading the myometrium but less than 50%, that's stage 1A. If it's more than 50% invasion in the myometrium, then 1B. If it's reaching to the cervix and it's involving the cervix, that's stage 2. And then 3 and 4, it's mainly for metastasis. But then after 2023, that changed, because now it matters if we're looking at a low grade or a high grade tumor. So I will focus now on the high grade, since the uterine serous carcinoma by definition is a high grade. So now if we're looking at a high grade that is involving only the endometrium, that is 1C. We're not even at 1B and 1A anymore. That's automatically takes it, we're starting at 1C. If starting invading the myometrium, even just like less than 50%, but once it's in the myometrium, that will take it to 2C. And let me show you here a picture to make sense of what I'm saying. So for example, seeing something like this before 2023, where it's just superficial, that would make it 1A. But now, according to the new FIBO staging, that's actually 1C. And I'm saying it's confusing or maybe kind of tricky because it's a transition phase that we are in right now. Like I know the majority of institutions now using FIBO 2023, or sometimes they even add both in the report. And that is because not everyone's still familiar with the new FIBO stage. And even if we are, if you go back to the literature, the majority of what you will see in the publications will be following the old classification. So that's why you need to just make sure and, like what they mean by 1B and what I actually want to know now. This like refers to what that we have now. And for the purpose of this presentation, because we will be talking a lot about staging, so I will try to tell you where the tumor is instead of using staging numbers so that no one is confused. What is the treatment options that we have? So there are surgery options, and that is mainly hysterectomies, whether we're taking the uterus out, maybe it's a radical hysterectomy where we add also part of the cervix and maybe upper vagina, or maybe it was a very aggressive tumor that invading everything, then they will do the debulking surgery. Other options are systemic therapy, mainly for chemotherapy, and then we also have an option of radiation therapy. And the question now is, okay, when to use what? Like, how can we decide which treatment the patient should take? And according to the NCCN Guidelines 2026, so this is the most recent one that we have for this year. So basically, when we diagnose uterine serous carcinoma, this is done usually by endometrial biopsy or maybe like curettage. So what we do is that after the diagnosis, the primary treatment for all patients is surgical treatment, whether we're taking like a total hysterectomy or maybe radical or debulking. So it depends on the extension of the, not really the extension, but if like, for example, we see mets that it's involving maybe the pelvic cavity, so we will go with debulking. So it depends on multiple things, but for sure, we will need to have the hysterectomy. And we call that the staging hysterectomy, because the idea of it is that now we have the whole uterus and we can stage. We can first confirm the diagnosis, of course, and then we can stage and see if it's invading myometrium, it's not invading, and then we can decide. So I tried to divide this into 3 major zones. For example, if we get the hysterectomy and we don't see any residual tumor at all, I call that a green zone. That is great news. You don't have to do anything else. Just keep up and follow with the patient just in case there is a recurrence or something. But the chances of recurrence are very low and everyone is happy. On the other hand, if we have something that it's very invading, and here this staging, even for the new guidelines, they are using the 2009 staging. And that's why I'm saying it's kind of like a transition. So here's stage 1A and stage 1B. And you will notice that they say invasive stage of 1A, because in the past, 1A was whether it's not invading myometrium or invading but less than 50%. So if it is invading the myometrium or more than 50% or less, if there is any myometrial invasion or any metastasis, then this is most probably will have poor outcome, and we should give chemotherapy to the patients. But then the yellow zone, or I should actually give it like a gray color and call it the gray zone, where there is residual, but it's not actually invading the myometrium. It's not invasive. And then the guideline says, well, you can observe or you can give chemotherapy plus or minus radiotherapy. So why this is kind of a gray zone? So let me like take a step back and again go through this. So the problem here is that 40% of the patients who are presented with uterine serous carcinoma, will have metastasis at the time of the diagnosis. So this is, remember what I said or called it the red zone. So already 40% will be presenting with metastasis. Usually when there is metastasis, it is through uterine lymphatics. And sometimes it's not just the lymph nodes, maybe it's actually reaching other sites, maybe the omentum, the red zone, give chemotherapy, maybe even adding great radiation to that. But 50 to 60% of patients who will be diagnosed with uterine serous carcinoma at the time of the diagnosis, it will be limited to the uterus. There will not be metastasis. And here it says, like, according to FIGO stage 1, according to the 2009 FIGO staging, it will be stage 1, whether it's A or B, even if it's invading the myometrium, but it's still within the uterus. It didn't leave the uterus and go anywhere else. And from this population, like, the statistics shows that only 30% will have recurrence. And that is the tricky part. And that's like what puts us in the gray zone, because, okay, 30% of this population will have recurrence. And again, I was talking earlier about the population that we're dealing with. This is elderly women. The median age is 72. So it's kind of a tricky, because can we identify who will get recurrence so that we give them chemo? Actually, we can't. Currently, we don't have any tools that we can use, whether like surgical, histologic, imaging, molecular. We don't have anything that can identify the 30% that will go through recurrence or will have recurrence. So that's why it's kind of like a gray zone. And that's why when you look at the guidelines for the NCCN, you will see for those patients, the majority will actually not have recurrence, but there's still a good amount that will have recurrence. So it's, you can observe, you can give chemotherapy. It depends on, like, you assess the patient. So it's kind of like a clinical team kind of call, but there's no specific thing to help us to identify those 30%. And what happens actually nowadays is that the majority, if not all the patients, are taking what we call the risk-reducing adjuvant chemotherapy, because we don't know who will have recurrence, so it's safer to give chemotherapy to everyone. But now the question is, if we can identify those patients who are at risk of recurrence, then that means there is a possibility that we can save the rest of this group of like low-grade FIGO staging uterine serous carcinoma to take chemotherapy. And because they are elderly women, so not giving them chemotherapy, that means that we are reducing the therapy-related morbidity, and theoretically that's improving the outcome for those patients. So now the dilemma, I would say, is that can we identify those patients? And I want to take this opportunity to thank Dr. Khalifa for giving me the opportunity to be part of this great project and be part of the team and participate in this. So basically, it was a very big project. It's a collaboration between us here, University of Minnesota, University of Wisconsin, and Yale. And the question that we were trying to answer here, can we use GATA2? Can GATA2 be that tool that we're looking for? Can we use the loss of GATA2 as maybe like a factor or something to help us predict the patients who will get recurrence when they have uterine serous carcinoma? And this article actually got published just a few months ago, like in April 2025. So why GATA2? Let me take a step back and tell you what is GATA2. So GATA2, it's a zinc finger transcription factor that regulates the transcription of many genes. And when I was looking in the literature, we actually don't know much about GATA2, but at least what I was able to find now is that GATA2 plays very important and essential role in hematopoietic development and the maintenance of the bone marrow stem cell compartment. And I just added here this figure to show you how much GATA2 is involved in hematopoiesis. We can have loss of GATA2, and when that is done because of a germline mutation, we have something called GATA2 deficiency syndrome, and that is associated with too many symptoms, diseases, and malignancies. And we can have acquired mutation where the GATA2 at this point, again, it's not too many projects or published research out there, but at least what we know now that it's linked when there is acquired mutation, that it's highly linked with de novo MDS and AMO. And also, GATA2, it's not just like hematopoiesis, it's actually expressed in other normal tissue, like maybe, for example, vascular tissue. The vasculature and the endothelium expresses also good amount of GATA2. But since today I'm here to talk about uterus, so of course GATA2 is expressed in uterus, and that's the link that I want to make here, is that GATA2 normally should be expressed in endometrial glands and endometrial stroma. And again, we don't have much research, but at least what we know now about GATA2 in the uterus is that it regulates the uterine expression and action of progesterone receptor. It regulates the epithelial differentiation and also regulates the ability of the uterus to support embryo and implantation. If you go and start looking at GATA2, I found one of like a published research where they knocked down GATA2 in mice and then see how this affect infertility. So it's kind of like mainly the things that we found out there that it's studied in the uterus context for infertility. But this is what we know now. So we know that GATA2, for a fact, is expressed in uterus. And GATA2 is linked with malignancies. So can we put these two facts together and study more GATA2 and see if there is loss of GATA2 in the uterus? Maybe this is also linked to malignancy. Maybe like can help us in predicting recurrence, predicting prognosis, and many other things. So we started with a small cohort. Let's call this the initial cohort, which is 70 patients from the year 2003 to 2012. And the median follow-up here is 3.3 years. And those 70 patients cover all stages, both the localized only in the uterus and the metastases. And to make sure that the cohort that we have matches the population, so we did something called population validation, where we compare it to I think like 1,700. I don't see the Zoom thing, but I think it's 1,700 patients from Sears, and it matched the Sears population. Maybe I would only say the only thing that we are kind of not really matching this population is that our cohort was leaning more towards specific race, which is white women. So GATA2 immunohistochemistry, how to interpret this? Actually, it's very easy to interpret it. It is a nuclear stain, and I added here an example on how it will look like when it's positive. And again, this is like the serous carcinoma, and you can see if the nucleus is brown or expressing the stain, that is positive. If not, then that is negative. And the range of expression, it should range from 0 to 100, like see how many cells expressing the stain and then give a percent. So we did that. And then as you can see here on the right side, these are the 70 patients. And we have like maybe 40 something cases that we divide them as GATA2 low, that has low expression. And then we have like the rest of the cases, the one that we give it the color red, as GATA2 high. So what is GATA2 low and high? So think of it like we did a multiple rounds to get this number or cutoff. So basically, we interpreted the stains and then compared that with the clinical outcome. Like we went back, check the clinical outcomes of patients, and then try to figure out where exactly we start seeing a difference in the outcome. And then the cutoff here was established as 15%. So if the tumor expressing, if 15% of the tumor is expressing the GATA2, then we call that GATA2 high. If it's expressing less than 15% of the tumor, then it's GATA2 low. And then now we have two groups, the GATA2 low and the GATA2 high. And we start comparing them. And as you can see here, Regarding the age, there is no much difference. The red, again, it's high. The black is the GATA2 low. And then when we compare regarding the tumor size, there is no much difference. But what we noticed is that the GATA2 high, which is this one here, they were having more of low stage, while the GATA2 low, they had more of their cases as a higher stage, like stage 3 and stage 4. And then when you look at the myometrial invasion, it's kind of like, I know it's maybe confusing to see this here, but as you can see, this distribution of data here and just like few cases here. So actually it's showing here that the GATA2 high show less myometrial invasion compared to the GATA2 low. And this table here showing the statistical significance between both groups. And you can see that there is actually not much statistical significance. Maybe I would say something that is statistically significant here is the myometrial invasion. And another thing that we also noticed is that the expression of the PR was slightly higher in the GATA2 high when we compare it to the GATA2 low. And it's kind of not a big surprise because we already now know that GATA2 kind of like works with the PR receptor expression. And then when we compare the survival, so you will see here, again, the red is the GATA2 high. So you will see that the cases, the GATA2 high uterine serous carcinomas will have superior cancer-related survival and also better overall survival when we compare it to the other group of uterine serous carcinomas that have loss of GATA2 or not expressing GATA2 more than 15%. And then we decided, okay, let's add more cases because, power in number. So now we have a cohort, and this is the final cohort, and of 195 cases. And this includes, again, all stages. FIGO stage 1 is the majority of the cases, 127 cases, but we also have FIGO stage 2. And again, this is the one in the cervix that involving the cervix, only 9 cases, and 58 stage 3 and 4, which is metastasis. So let's first start with seeing GATA2 expression in the metastatic uterine serous carcinoma stage 3 and 4. And we're trying to see here if it is predict the survival maybe, and if it affects the response to chemotherapy. So first, let's go through survival. So you can see here, when it is metastatic uterine serous carcinoma, it didn't actually show any difference in overall survival. Both groups, the GATA2 low and GATA2 high, did not have the same survival. And so basically there is no predictive value of survival, and that can make us suggest that maybe there's actually no difference in response to chemotherapy happen due to GATA expression, because whether the tumor express it or not, the response is the same. And I'm saying that because when we're having a metastatic patient and who is on chemotherapy, usually the survival here is based on how much this tumor is responding to chemotherapy. So if the response to chemotherapy is the same for GATA2 high and GATA2 low, and the survival is the same, so it kind of means it's not really affecting response to chemotherapy. And this part is very cool. So these two charts actually they were done at Dr. Mattson lab at University of Wisconsin. He's the PI of this project. And we kind of wanted to prove, is really GATA2 can affect the response to chemotherapy. So what he did is that he had patient-derived uterine serous carcinoma cell lines, and he was able to deplete the GATA2 using the siRNA, and then starting to compare these cell lines with different types of chemotherapy. Usually the chemotherapy that we use in uterine serous carcinomas, the paclitaxel, and also the carbapenem, and then having these cells it's kind of expressing GATA2 and depleted GATA2. And then we have the chemotherapy on both cells. And you can see when we're having this, there's actually no difference at all, which kind of confirms that what we see in our cohort is correct. Now let's focus on the FIGO stage 1. So now we're done with the metastatic stage 3 and 4. Let's focus on the uterine serous carcinomas when it is confined or kind of like limited only to the uterus, whether it's invading the myometrial or not. And as I mentioned, we ended up with 127 cases. I would say this is here all the like how our cohort looked like, but I would just want to point something that the majority of the cases that we had in this cohort, although it's kind of like covering all stage 1, A and B, which basically means all uterine serous carcinoma with and without myometrial invasion. But the majority of the cases, 106 of the 127, which is like 83%, they actually were stage 1A, which means it's whether just in the endometrium or if it's in the myometrium, it's less than 50%. And I would say actually half of these cases, 45, maybe even more than 45, I think maybe like 50 something, if I remember correctly, were just confined to the endometrium. It's with no myometrial invasion at all. And then we will do the same thing. Now we have this group, but now we're talking about the FIGO stage 1, not the metastasis. We did the GATA2 staining and then divide them into 2 groups. The one expressing more than 15%, it's GATA2 high, less than 15%, it's GATA2 low, compared to 2 groups. And you can see here, these are the cases that have the GATA2 high, and we ended up having 33% of the cases GATA2 high, the rest are GATA2 low. And then when we compare the age of the 2 groups, you can see there is no much difference. When we compare the tumor size, there's no much difference. And then again, this is the statistical differences between these groups, the GATA2 low, GATA2 high, and again, it's the FIGO stage 1. But this time, there is no statistical difference at all, even in the myometrial invasion. And maybe I would say this regarding the myometrial invasion, at least it's not, like we shouldn't take this as like, I don't know, I feel that we're kind of biased here because the majority of our cohort to begin with did not have myometrial invasion. So that's why it's not really reflecting and showing if there's any statistical significance. So that's why I added here a star. And the PR expression, it was very close to be statistically significant. And then for the survival, what I found really shocking. So 0%, not a single case with FIGO stage 1 uterine serous carcinoma had recurrence. Not a single case. There is no recurrence, but the GATA2 low, this is the GATA2 high. The GATA2 low, there were recurrence. We found recurrence when we did the follow-up and then, or we collected the data of the follow-up. And accordingly, when you look at the cancer-related survival and the overall survival, you will see that it's better in the group that is expressing more GATA2 or what we call the GATA2 high. And the overall survival here, I know it's not statistically significant, but it's very close to be statistically significant. And now that we know this, now the question becomes, can GATA2 regulate invasion? And to be honest, we did this step because we're trying to understand how GATA2 do that. Like we have a very shockable results. Like, did we really find a marker that can maybe help in predicting recurrence? How does it work? How GATA2 work? Does it help in maybe affect invasion or something? Like we were trying to understand more. And again, this is this part here was done again in Dr. Matson's lab at University of Wisconsin. And again, he had, or the whole group, because the patients that they used here, the patient cell line, it's kind of like from different institutions from like that participated with University of Wisconsin and also Yale. So it's kind of still a collaborated part, although it was done in his lab. So what they did is that we have the patient-derived cell lines that it had uterine serous carcinoma, and these cell lines were variably expressing GATA2. So it's kind of like mimicking our data or our cohort. And then again, they were able to deplete the GATA2 using different approaches, whether using siRNA or using the shRNA. And you can see here, this is showing how they did it. And I'm not gonna lie, I don't understand the nitty-gritty details of how they did this, but they did. And then now we have these cells that are GATA2 depleted, and we have other cells that are expressing GATA2. And what they were trying to do here, what Dr. Matson was trying to do, is that we're trying to make something mimicking the basement membrane. So this is like a chamber assay where we have two baskets. So the top basket here is filled with low serum, and then we have the bigger basket, the one at the lower part, where this has high serum. And then between these two baskets, there's this membrane. It's a matrigel coated membrane. And the red dots here are the cells that are whether GATA2 depleted or still expressing GATA2. And if cells can invade that membrane and go from low serum to high serum, it's kind of like the in vitro part where it's kind of like trying to imitate invasion in human cells. And indeed, that GATA2 depleted cells were able to invade this membrane within less than 24 hours. And I'm almost done. I know we still have time. Okay, that's good. So at the very beginning of my presentation, I was saying, I kept repeating, like, we want to identify this 30% of patients if we can, like, hopefully not give chemotherapy to everyone when they don't need it. And now the question is, as I mentioned earlier, the majority of the cases nowadays take chemotherapy. So we were trying to see cases or identify cases that actually did not have chemotherapy at all. So there is no other things that are biasing our results. And just study this and see if GATA2 can actually predict recurrence or not. So as I mentioned, it's not really like a lot of patients that don't go and proceed with adjuvant therapy, but we were able to identify 24 cases. I know it's not a lot, but it's a lot compared to how the management is now happening. So we were able to identify 24 cases, 10 of these cases, and of course we did the GATA2 staining for both, the immunohistochemistry. And then 10 of these cases, they were GATA2 low, again, expressing less than 15%, and 14 cases were GATA2 high, which is expressing more than 15%. So now it's kind of like a, I don't know, like third or fourth mini cohort that we're playing with to understand more and see if really GATA2 can predict recurrence without any other external effects. Maybe I would just add something here that there were like few cases, 5 or maybe like 6 cases did not have chemotherapy, like all of them did not have chemotherapy, but these 5, 6 cases had radiotherapy. However, I would say the radio is not as like a mandatory step that they do when we say adjuvant, like it's a plus or minus, but we're mainly focused on chemotherapy. And also, when we're trying to see this group of patients where they lie, if they are in the GATA2 low or GATA2 high, you will see that it really doesn't show much of statistical significance. So that means it shouldn't be a big deal in interpreting our data. And then we did the same thing. We have the two groups, the GATA2 high, the GATA2 low. And now we're looking at patients who have uterine serous carcinoma, FIGO stage 1, which means the uterine serous carcinoma is only limited to the uterus. And again, shocking results. These patients did not have chemo. And to be honest, I'm not really sure why they did not. Maybe it's a clinical decision, maybe the patients opt out, but we're dealing here with patients who do not have chemo. And all of the cases who were classified based on our staining as GATA2 high, none of the cases had recurrence, 0% recurrence. Well, the cases who were classified as GATA2 low actually showed recurrence. I still see that very, like, I don't know, it's very shockable data. I still amazed on this because it gives me like, GATA2 can actually have a very important role in our practice. And then when we see these results and the recurrence and then look at the overall survival, it kind of makes sense where when we have the population that are GATA2 high show better overall survival compared to the population, the black line here, which is GATA2 low. So what we have now is this on the left side. And this is the guidelines from the NCCN guide, the one that we have recently. And again, to just like refresh your memory, what they are recommending is that if we have FIGO stage 1A, the non-invasive, it's the gray zone. Observe or chemo because we know only 30% of those patients will have recurrence. If there is invasion, do chemotherapy because most probably the outcome will not be good. What we are proposing is that maybe GATA2 can actually play a role in helping us and the clinical team to identify this population that are at risk of recurrence. So based on the data that we have, the FIGO grade 1, GATA2 high, maybe they will only need to do the hysterectomy surgery and then closely have like the clinical team observe them because the chances that they will have recurrence are not really great. However, if they are FIGO stage 1 still, even with or without invasion, but they are having low expression, then most probably those patients will have recurrence or a poorer outcome. And I just want to stop here for a second and say something. This project is not to replace any clinical trials because this is a big move to change the recommended guidelines. This is not something that can be done only by one project. So definitely we need clinical trials to be able to say, yes, we can use GATA2 and implement GATA2 in the management plan. But hopefully our project would be at least opening new doors to new perspectives that no one ever thought of before. So the take-home message, if you only get this slide from my presentation, I would consider this as success. So to summarize what we went through till now. So basically, if you have a uterine serous carcinoma, and this uterine serous carcinoma is expressing GATA2 immunohistochemistry, and I just want to say something that patients who went through through chemo and everything, like the expenses of using IHC, it's not that much. So if we even at some point planning to do it, maybe to increase our cohort for future projects, for example, and I will talk about my future project now, but the thing is, it's not really expensive to do one immunohistochemistry that might save some patients in the future from, and like elderly patients, to go through chemotherapy. But the goal of this presentation, what I want everyone to know by the end of this presentation, since we're finishing, is that if you have FIGO stage 1 uterine serous carcinoma that is not involving anything but the uterus, and you do the GATA2, if it's expressed in more than 15%, that's great news. Most probably, those patients will have better outcome than the rest of the patients, and most probably, they will need just observation. But if you have loss of GATA2, then most probably those patients at some point will have recurrence. They will have poorer poorer outcome because of the loss of the expression of GATA2. So those patients most probably will need to have adjuvant chemotherapy, whether it's chemo or chemo and radiation. And one last thing is that, again, I know that still a lot of research is needed and a lot of clinical trials is needed before we get to a final conclusion. And like one of the limitations that we have, as I mentioned earlier, is that our population was kind of leaning toward a specific race, which is the white women. So what I'm working on now with Dr. Khalifa is that we're expanding this project, actually. We're focusing on the population of Black women. So now we have a big cohort of Black women and women of color. And we're also expanding our understanding of GATA2. So now we're not just studying the uterine serous carcinoma, but we're actually trying to include more different carcinomas like endometrioid, clear cell, triple MT. Like, we're trying to understand, it looks like there is a potential in GATA2 expression, and that's why we need to like expand our knowledge and expand our research to try to understand more of how we can use this for the benefit of all patients. And these are my references. And I want to take this opportunity because it's very rarely that I have a chance to meet all of you in one place. So I want to take this opportunity to really say how much I'm thankful and grateful for each and every single one of you. I wanted to add way more names on this slide, but space limitations, but really each and every single one of you played an important role in their continuous support, teaching, and guidance. Because of your continuous effort with me, and I know that all trainees feel the same thing, we are very grateful, and we are what we are, who we are today because of your effort with us. So really, thank you so much. And big thanks to our residency leadership, Dr. Furkat, Dr. Khalifa, Dr. Colleen, Dr. Dolan, Dr. Johnson, and Dr. Zong, and Maggie and Gabby, and many thanks to my mentor, Dr. Beckman, and special thanks to Dr. Khalifa and Dr. Klein, because they made me fall in love in breast and gyne. So I really appreciate this. And I'm looking forward to learn more from them and work with them next year in my fellowship. And big shout out to all trainees, residents, and fellows. You made my residency journey very enjoyable and very fun. And especially my class, Bashar, Ryan, and Darby. Thank you so much, everyone. And with that, I think we have like maybe 10 minutes. So thank you so much all for being here today. And I would be happy to answer any questions or take any comments. Yes, Dr. Yohi.
Great talk. It was a lot of fun to listen to. I have a couple questions. So one is, as we know from previous examples of using IHC as a targetable biomarker, especially if there's a specific cutoff, there's a lot of analytical, pre-analytic, et cetera, considerations. So my question for you is more about the technical aspects. Was the IHC read in just one lab? Was it done in all the participating institutions? Were they all using the same clone for IHC? You know, some of those details to see how reproducible, you know, it's going to be to interpret this IHC.
That is a great question. So yes, so here's the thing. Actually, University of Wisconsin are the ones who developed this antibody. And they did their studies before starting giving us the antibody. So what they did is that they had, like they used the mouse and then the rabbit and compared, and it actually showed the same like sensitivity and specificity. So they decided based on their data to go with the antibody that is like mouse, coming from mouse or mice. And what they did is that because they also didn't want to bias us in interpreting. So by the time we were interpreting this data, the cutoff was not mentioned. Like, we don't know the 15 plus or minus, so that we didn't want, and that's why I said it was kind of like going back and forth. So what happened is that they gave the antibody to us here at University of Minnesota and to Yale. So we all used the same antibody and the same clone. And each institution used the antibody in their lab. So we did our cases in Bionet. And then the interpretation also were done in each institution separately without knowing. So it was, I removed a lot of like details, but when we did that, actually we were blinded to the cutoff so that we're not biased. And also we were blinded to the clinical information for our patients that we are interpreting. So it was kind of just our goal to GATA2, the information that we have, GATA2 is expressed in uterus, endometrial glands, and stroma. And here's the tumor, interpret this and give a percent. So it was kind of like very blinded. And then after collecting the data, we put everything together, and then we started like going back, and we were trying, yes, there is still like a difference in because different labs. So I can't say that it was 100% the same in all labs, but at least we tried to use the same antibody.
No, that's good. I mean, that actually at least shows that interpretation across labs may be fairly consistent. So, and then my other question, of course, because I'm a molecular pathologist, is, you know, a lot of our internal cases, GATA2 is actually in our underlying NGS platform. And a lot of these cases may have had NGS done already. Is there any plan or interest to see if there is any underlying genetic change that correlates with the IHC?
I know that this was one of the goals in this project, but to be honest, nothing was really like at least in our cases, like in our University of Minnesota, we were not able to do that and find if there is any like other thing underlying this. But I hope that in the part 2 of the project, and I'm not sure if part 2 we're also going to make it like a collaboration to have like bigger cohort, but this is definitely on the table to like, how can we use molecular and NGS in helping us in this, like seeing this, and see also like maybe there is like because having loss of GATA2, that means that most probably there are other genes and other mutations are happening. So if we can see like maybe the pathway, if we can understand more of the pathogenesis, that would actually help us to understand more GATA2. So right now, I'm sorry, I don't have much information about this, but it's definitely like on our goals for the next step of this project.
Future plans. Yep. All right. Thanks.
Thank
That's
you.
my questions.
Do we have any other questions or comments?
Dina, this is Molly Klein. Thank you for an excellent talk. I really enjoyed it. Very informative. Yeah, I think you're absolutely right. Like this is a step in the very much a step in the right direction, and you guys obviously put a lot of thought and work into this. But it is tough with immunostains, and I'm ever the pessimist. So whenever I see a 15% cutoff, I think, oh my God, what about when I think it's 14% or 13% or 16%, right? So yeah, anything that we can do to try to make that more precise. I mean, in this study with this immunostain, you had to choose a cutoff, and I think you showed why you chose that level. But for someone like me who's spatially challenged, just bare minimum, like image analysis would be super nice if you're really going to use that cutoff for treatment, for ultimately, if that's going to be the case. But yeah, if we could get a molecular test that could give us more of a yes or no answer rather than a range of answers, that would be super helpful. But yeah, thank you for your work, and thanks for the presentation.
Thank you so much, Dr. Klein. And I agree with you, like with all interpretations with percent, I also struggle. Like it's kind of like very subjective. So hopefully this would be just the beginning, and hopefully in the future we will have like more definitive like steps on how to interpret this. And if we have molecular, that would be even better because it will not be subjective anymore. I completely agree with you. Thank you. Dr. Crossan, you have a question or a comment?
Yeah, thank you, Dina. That was very interesting. I just want to ask you if you have a fairly good physiologic explanation for the differences that you observed between the GATA high and the GATA low.
I would honestly I would say based on the data that we have, there was no much physiologic differences because we were trying to look at all the parameters again. Like whenever we have the two groups, we compare everything, all the data that we have, like age, tumor size, maybe hormonal expression, even like the small details. And that's why I would say the only bias I would say that we have is that we're having like the majority of our cohort is like in one race. But other than that, we actually didn't see much like significant difference between any of the parameters between all patients from both groups, GATA2 high and GATA2 low. And that's when we did this, like on the many cohorts that I went through, like whether it's metastasis, whether it's like the low stage, whenever we compare the GATA2 high and low, we didn't actually see that there are other differences. Maybe like the myometrial invasion was playing a role, or there is a significant difference. But like physiologic difference, I would say we didn't find much. Hopefully, like the plan again is to like 195, it's a good amount of cases, but again, it's not enough. So hopefully when we're now expanding, we're having more diversity in the cohorts, bigger number. So maybe we will start picking up some other differences, but at least based on the cohort that we have now, we didn't notice much difference between both groups.
Okay. Yeah, I certainly agree with Sophia that adding genetic information to this will be very critical.
Thank you so much.